We're going to move to another controversial topic, which is now not on the topic of good risk disease, but intermediate and poor. And the question I have for you here, and I might start with you, Tian, is there a role for TKIs in this setting alone as monotherapy? Are there certain patients who you might choose for that purpose?
Yeah, so, in this setting, I really do debate about ipilimumab, nivolumab combinations versus, say, cabozantinib in the frontline setting based on CABOSUN. And the patients I generally try to choose for cabozantinib or VEGF TKI would be patients who have, critical metastases at specific sites of disease. So, say they have a MET in the spinal column that might have some epidural extension, and I'm afraid that any local inflammation might tip them over toward cord compression, or they have a lymph node in the retroperitoneum that's pushing on a ureter and causing some mild hydronephrosis. If there's any inflammation there, maybe that gets worse and the kidney function it worsens. And many of these patients, as you know, have only single kidney, so their renal function is pretty tenuous. So anything like that where a structure can become inflamed and cause some obstruction and cause further clinical problems and symptoms, I'm leaning toward using a more directed therapy for early disease control and a faster response.
That sounds like a brilliant approach. Niraj, what do you think?
I'm very intrigued by this approach. I think this is very similar to what I have in my mind when I'm seeing these patients. But I just build up on what you just said. So yes, we are looking for those patients who do not have the time to wait for the responses or progression-free survival benefit. They need immediate benefit. And we know that there is a large number of patients who may not achieve a progression-free survival benefit with ipi/nivo. Yes, we are really excited about the complete responses, but on the other side, there are going to be maybe 30%, 40% patients who may not see immediate benefit. So when I see high volume, rapidly progressive disease, especially with bone metastasis, liver metastasis, and again, as you said, cord compression, impending cord compression, I tend to use cabozantinib first, followed by nivolumab or ipilimumab nivolumab both.
I think that makes a lot of sense. That tends to be my algorithm too. High risk, rapidly progressing disease, bony mets. I think cabo is a very sensible strategy. I'll also just throw in there too that if I see patients, and I'm sure you guys do as well, who travel quite a distance to the tertiary center where they may not have appropriate follow-up for autoimmune related side effects, those are also patients where I sort of think about using a TKI up front.
That's a great point. Yes, we always have those patients who are elderly, frail, living 100 miles away and commute 3 hours to come to the cancer center, how good they will be in responding, how responsive they will be to our directions of calling us with 5 episodes of diarrhea, right? So I think those patients are who are already vulnerable and who may not be as communicative. I think those are the patients I really worry about ipi/nivo combination.
Absolutely. I think, sometimes in that very frail population, those patients are not the patients that are going on clinical trials, right? The people who come in a wheelchair and are really quite frail and have really large disease burden. Disease burden is something that we see on scans and doesn't quite make it into our risk stratification, but I think it's something very real that we all take into our clinical impressions when we're thinking about these patients. And so when people have very high disease burden, they need a quicker time to response, these are the opportunities where I think TKIs, and we'll get into TKI plus immunotherapy combination strategies in the upfront setting, can get them to an earlier response.
Makes sense, makes sense. I saw some great data at ASCO GU not long ago from the Farber group. And Brad, I think you were part of this abstract as well, looking at autoimmune disease and immune therapy. Can you give us a sense of what to do for that population? Niche population, but I think we all see it, right?
Right, I think this was a study that was retrospective, looking at patients who had a history of autoimmune disease that were treated with immunotherapy, and it seemed it was safe. It required monitoring, but it was done, when done appropriately with appropriate follow-up, despite a history of autoimmune disease, it could be done safely. Now, granted, these were not things like an active Crohn's colitis or something along those lines. These are a history of autoimmune diseases, often maybe something like rheumatoid arthritis or something that, would not be life-threatening should it go out of control quickly. But it certainly seems like a history of autoimmune disease, especially if it's been relatively quiescent, should not be an absolute contraindication to immunotherapy, though on all the clinical trials, that is certainly the case.
Yeah. And those patients were excluded on the trials, right? And so your data really helps kind of put in a perspective of what we do in clinical practice and try to manage these patients. You know, they've had this long history, but they're on, you know, very low steroid doses or nothing at all, or some NSAID doses. And, you know, while we're treating them with immunotherapy checkpoint inhibitors, we're also watching their symptoms very carefully.
Do you have sort of a line in the sand for this, guys? If a patient, for instance, comes in on Remicade, for instance, is that a patient who you might consider for Nivo and Ipi?
I won't.
Yeah.
Yeah.
What do you think?
I think,
Gian?
you know, when you talk about looking at patients with autoimmune diseases, there's a whole spectrum, as you said. Autoimmune hypothyroidism is different from Crohn's or ulcerative colitis. So yes, there is a spectrum. And yes, I think milder form of autoimmune diseases must be fine. It should be okay. We see them all the time. But anybody who has any clinically meaningful autoimmune disease requiring active treatment, I will not think about checkpoint inhibitors in those patients.
That makes sense.
I think a steroid dose, you know, prednisone equivalent of 10 milligrams or less a day, you know, those are the patients that I would consider. I agree, absolutely, anybody who has a true disease-modifying agent like Remicade or Humira, you know, those patients are you know, high risk for flare-ups, especially if we're activating their immune systems. And I absolutely would hold off on checkpoint inhibitors in
And
those
also
patients.
I worry about, like, if they're already on so many immunosuppressive medications, I worry about like the efficacy of
How-
immune checkpoint inhibitors in those patients.